Mr. Capps is a patient of ours. He came in, he had a couple AFOs, and he just, one of the hinges had broken and he wanted me to repair it. And I took a look at him, as I do with all my patients, just to see what I was dealing with. He told me he had a spinal cord injury, has a drop foot on this side. That was his primary concern, is the drop foot, catching the toe. But he had a few other things going on that I found in my evaluation. And the injury was a few years ago. Okay, he's had a couple braces made, and I'll show you those. But in my evaluation, what I found is he's got hyperextension at the knee. That is a concern. And when I take patients through range of motion, what I want to do is isolate the heel, limit any valgus or varus movement. So I just grab the heel and keep it vertical. And I get the second toe in line with the knee, and that's just a general line of progression, slight toe out, typical alignment for gait. So when I stabilize the heel, and when I try to dorsiflex him, you can see I'm putting a fair amount of pressure there, and you feel that stretch, right? And he's not getting to neutral, okay? Now he can get to neutral. What he does to get to neutral is he goes into that typical internal rotary deformity positioning, the heel slides out, midfoot collapses, and the forefoot slides off into abduction. So we can get into 90 if we do that, but you see the arch collapses here, and we're really getting a stretch in here. So in order to get him into good alignment, we're going to have to deal with this contracture. Now I've found that I can go ahead and make the brace at 90 degrees, and he'll get down and we'll control the heel. He just won't be able to tolerate it for extended periods until he gets this muscle stretched out. So what he came in wearing, and his favorite brace is this one here. He's had it since, well, the 90s. So I guess, yeah, this was actually quite a long time ago that he had the injury. And he's got the gummy bears, the Gillette dorsal-assist joints. But what you'll notice here is that they've not, when they casted him, they got into 90 degrees, so they've got no arch. And that's how they built it, with no arch. And they've taken and they've flattened out the heel. So he's got this wide foot plate here that really doesn't fit his foot very well, and really doesn't support the arch at all. So if you look at it, there's a big old gap in here, and we're really not doing him any favors. I don't know if, go ahead and flex your knee. I don't know if you can see in there. There's a gap all through here. And a lot of practitioners do that to eliminate navicular pressure, but the better way to eliminate pressure is to control that motion, to get a tighter fit and not allow the collapse. So this design is fine for a drop foot, and he walks around okay with this design. But what it doesn't address is the plantar flexion contracture or the hyperextension at the knee. And of course they go hand in hand with that plantar flexion contracture. That makes the knee want to fall into hyperextension. So then he had another brace made, and this one took into consideration the plantar flexion contracture by putting a plantar flexion block on there, which also helps to compensate for the hyperextension at the knee. The problem was this foot plate was made so wide that they're not controlling anything at all. And when you take a look at it on his leg, it's pretty sad to fit. Now I'm not saying maybe he lost weight, but this brace fits well, and it's older, so I doubt he changed that much. But you can see just the gross, terrible modifications that this AFO was made on. Huge gaps here, a sabotage trim, I guess some people call it, which doesn't even touch the leg. We're not getting any correction here, so that could just be hacked off. I don't know why it's there, except maybe you can bill for it. I'm not sure, but if I'm going to use a sabotage trim, which I never do, and I see that this is the fit I'm getting and I'm not getting correction, we'll cut it off if it's not going to do anything. So the problem with this one is it takes up so much room in his shoe, okay? But it works, okay? It holds his foot up, and that's what he was wearing when this one broke, but he wanted to go back into his old one because of the fit of this one. There's no control, no support. He moves all around inside it, but it holds his toes up, which is his primary complaint. most people, or a lot of people, may disagree with my recommendation for him. We have a triplanar issue here, okay? We've got a plantar flexion contracture, we've got hyperextension at the knee, we've got an internal rotary deformity on the tibia of the tibia on the talus, so that the heel slides into valgus, midfoot collapses, forefoot slides into abduction. So this isn't a simple drop foot. This is like your typical posterior tibialis tendon dysfunction, where you've got a contracture. So you got a posterior tibialis tendon dysfunction with a drop foot. Okay, so which one is more pressing that we treat? Well, the posterior tibialis tendon dysfunction, because that's a triplanar instability. A drop foot is a simple single plane. You can put them in an Autobach walk-on AFO or a hinged AFO, free motion dorsal assist. But because he's got the triplanar instability due to the plantar flexion contracture and the hyperextension at the knee, he needs more control. So I put him in my dynamic AFO design, which I call Turbo, for lack of a better term, which basically incorporates a very long strut, okay, but it's very rigid. So if you take this device and you torque it, okay, for gait, this has good rotational control. Rotational control is important when that midfoot wants to collapse. When the midfoot collapses, this is going to want to rotate out. And if you don't get adequate rotational control, well, you're going to get a lot of arch pressure. If you take this design here, this is not a triplanar design by any stretch of the imagination. No rotational stability whatsoever. This one is a little bit better, but still, you've got a lot of rotational instability. There's no reinforcing plastic. This is 3/16 polypropylene with a 1/8 inch polypropylene strut extending from the medial arch all the way up around over the lateral malleolus to the bottom of the AFO. So we're able to get rid of a lot of plastic. We have a very rigid dorsiflexion resist, which will aid in toe off, which his plantar flexion strength is okay. But because of all the other issues, he's not going to really be able to work those plantar flexors when I lock him up. So the brace is going to compensate for me not allowing his plantar flexors to work. But that's something that we give up in order to get the best possible result from the design. He was interested in this, and I told him about my design, and he had two braces that were actually working. But I told him that we could make him something that would work better than anything he's ever had. And now it's up to me to live up to that. I'm going to ask him to walk in the bars just so we can get an idea of his gait pattern. You can see when he's walking, he's looking at the floor. He's bent over forward. He's got to look and see where that foot is in space because of that foot drop. Now look at the midfoot collapse. You see how the arch is collapsing and hitting the floor. That's triplanar. And if you'll look coming back, and it may be difficult to see, but I think you'll see it, the heel is slid off into valgus. Because of the tightness of the calf muscles, they're torquing that heel off. And the hyperextension at the knee is not real prominent. It's actually fairly mild, but it is there. And you can't really see it in his gait pattern, and it's minimal. It's just a few degrees, but there is some hyperextension. Okay. Now, I've already fit it and trimmed it, and I've had him walk in it. So that's basically minimal coaching. I just had him walk in it, make sure that everything was okay, trimmed everything down to fit the shoe. So he's already been up in it, but this is his first real go-round. Now, when I fit this, you can see that, I want you to look, Chris, his foot, because I'm trying to bring his foot up to 90 degrees, his foot wants to slide over this way, okay? And that's not good. But what he's going to do is he's going to position his foot over the AFO and then put his shoe on. His shoe is going to block that 4-foot deviation. I could use a long lateral trim here to control that, but then he's got to get a bigger shoe. I want to get him in a shoe that isn't going to be huge on the other side, and the shoe will control that. And if we get a little bit of lateral drift, I'm not overly concerned with that. As this muscle gets stretched out, that will go away, and we'll deal with whatever problems arise. One thing that he liked about it, also what I put inside these is a SAT heel, a shock-absorbing heel. It does several things. It absorbs shock at heel strike because it minimizes the flexion moment at heel strike. It also serves as a little cushion, a shock-absorbing cushion. It also pitches the knee forward. does two things. Limits progression of the hyperextension, but also at mid-stance he's in slight flexion, which is our normal position in standing, is about 5 degrees of knee flexion. So he'll stand in a comfortable position. Also, at heel strike and foot flat, if you're at 90 degrees, it's hard to start out when you've got a toe block and a knee at 90. But if you shift that knee forward a little bit, he's already set to roll forward. And